Warning, the following conversation features fierce women, once high school acquaintances, now friends, who talk about real topics that most people either try to avoid or pretend don't exist. In here, it can get messy, but it's always the truth. Welcome to The Messy Truth.
Okay, hey girls.
Hey,
I didn't say acquaintances this time.
good. We're over that.
You can see that somebody new is here today. This is my sister Karen Avery, and I'm down in Nashville. Came down here to help somebody make some icing flowers. That's a side story, but anyway, no, so yeah, I'm here in Nashville for the week visiting. To stay with my little big sister. I call her my little big sister because she's littler than me in size, but she's older than me. Not necessarily
just a little bit older.
Yeah, yeah, just a little bit.
We're Irish twins.
Aw.
So I don't know if you girls remember, but Karen was our guidance counselor when we were sophomores in high school at Waukegan.
I don't. I was academically checked out. So I was just interested in my pom-poms and my cheer skirt.
So I'm
So.
automatically going to take a tangent right away because this just came to mind when you said you were academically checked out. I
I know this story.
I wasn't the greatest student myself. And remember how we would get 5-week notices if you were failing a class before the report card came out? Yeah. So,
Yeah.
I got a 5-week notice that was mailed to me, and it mailed to my mom's house, my mom and dad's house. And I saw that it came in the mail, and I got the mail that day. And I opened up the 5-week notice and saw the grade in whatever class it was that I was failing or not doing well enough in, I guess. And I guess I would have to be failing if I had a 5-week notice, right?
It was English, I know, but definitely.
But it wasn't.
She remembers.
No, that was my freshman year with Mrs. Roddy. I was missing a 39 assignments out of 41. Anyway,
Oh my goodness.
another time, because that is a really funny story about parents. Well, if we ever have a topic about parents.
Well, isn't that when you took the 5-week notice and you burned it?
I burned the 5-week notice because you don't leave any evidence behind. And so somewhere along
Well,
the
then
line,
you told me about it, but she told me in school, and then got this confidentiality thing, and
yeah. So my
then
mom,
we know who to call when we need to like hide the body. It's Becky.
just make sure you pay her $1 first as a therapist so she can keep the
Yeah.
confidentiality. But later on, at some point, my mom was like, when the report card came, she's like, I can't believe I didn't get a 5-week notice about this. And Karen, she was saying it to Karen, and Karen was just like, anyway, so that's the guidance counselor story. So anyway, we're going to talk about anxiety and depression tonight, since Karen is a licensed mental health practitioner.
counselor,
Counselor,
yes,
licensed mental.
practitioner.
So she, is basically a therapist, and has been doing it for more than 5 years.
Yeah.
But
And when Becky actually made my website, and I get a lot of comments on my website.
oh yeah,
Yeah, that you made. It's really
nice.
good.
Awesome.
AveryCounseling.com.
yeah, averycounseling.com. And no, so when I say more than 5 years, we're just joking. It's definitely way more than 5 years.
We don't want the number. We don't really need to.
Yeah.
It's not good.
So we're going to talk about that, but because we were trying to figure out how much of this mental health, like what aspect of mental health we should talk about, because we wanted to take advantage of her expertise in her field. But so when you hear anxiety and the words anxiety and depression, like what's one of the first things that come to your mind?
Are you asking them or me?
I'm asking
Oh,
you.
you're asking me.
Yeah.
I guess it depends on who's saying the terms, because I think lay people use clinical terms all the time, and they've lost their kind of meaning. We'll say somebody, oh, they have OCD, or they're just being anxious, or they're being schizo or and we're really diminishing the clinical aspects of these disorders. So it depends who's saying those terms to me. I think different things.
Yeah, but so earlier when we were talking today, you had mentioned you were talking to me and Maureen on the phone about anxiety and how, I don't know, you remember.
Differentiating the
Yeah.
different, okay, so if a client comes and they're saying that they're struggling with anxiety, of course, the first thing I'm going to do is do a full assessment, and I very methodically go through checklists just to see, because you might say it's anxiety, but after a checklist, I might realize it's not really anxiety, it's really stress. So identifying, are we talking about stress, which is usually the body's response to an external stimulus, and anxiety is the body's internal reaction to something that's ongoing, usually physiological or genetically predisposed in nature, but they can kind of go like this. So trying to discern with the person, is it just stress? Not that stress isn't bad, but we can problem solve stress a little easier than we can anxiety. But either way, there's particular tactics and whatnot that we can, try to figure things out.
With anxiety, is there a difference? Well, I'm sure there is, but I guess I'm asking the major difference. So what is the difference if somebody maybe was born with anxiety, and how would you know that? And or somebody all of a sudden just at a certain age becomes more anxious, and then that starts coming out. And how do you know that they didn't have it earlier and then all of a sudden it's rearing itself?
Well, when
or if it just cropped up?
Yeah, no, that's a great question. So that's why it's so important for clinicians to be doing a full psychosocial assessment, so that we're getting an understanding of who you are now, what your symptoms are right now, but who are your people that you come from genetically. So the questions we ask are going to be getting that information from you actually in an intake kind of packet that would, you would have filled out prior to, and then the clinician should be following up, asking very specific questions. So anxiety usually has some kind of genetic coding to it. So kids, somebody may come out, let's just say there's a set of twins and they get adopted in 2 different homes, and there's a genetic predisposition for anxiety there. So if the environment of one home is really stressful, it's fairly dysfunctional, emotional dysregulation, well, that could ignite then the anxiety to flare, where that same anxiety genetic predisposition in a really stable environment, solid parenting, things like that, it could mediate it or lessen the experience of that. So it is kind of a complex thing, but essentially we're trying to differentiate is what the person is experiencing has to be in the here and now. So when I'm asking somebody, I need to know what you've been feeling really the last 2, 3, 4 weeks. Then people are going to go back into a history of what they've experienced the last 5 years, which is very, very important. But in terms of diagnosing, we're looking in that moment. So in reference to kids, we know that between like 15 and 25, you've got the hormones coming. That's when, a lot of mental disorders will show themselves. That's typical.
Mm-hmm.
And I think the experienced clinician is able to separate out what's normal teenage angst and what is clinical in nature. And that can be tricky.
Yes.
But
that scares me. That part right there scares me, because a misdiagnosis is so scary for somebody that's younger, especially. I feel, scary for anybody, but somebody in that range, I feel.
Well, that brings me to, because I'm writing things down now as they pop into my head, because now I'm having more questions than probably we even have a time for. But I wrote down that it feels to me, compared to when we were all in school, that there's teens today are on anxiety and depression meds way more.
Oh my gosh.
Than,
yes.
And so like, What do you
Well,
think about that?
Yeah, I think it's some of it's what we call first world problems, which, if you take any of us going through any of that and dropped us in the middle of nowhere and we are on Naked and Afraid for like 6 months, we're not going to be stressed and anxious about the things we are now because our hierarchy of needs has gone primordial. We're focusing on where we're going to eat, where we're going to sleep, kind of the basics. So I do think those numbers grow with the culture that we're in. And, so we have very high numbers in that regard.
I mean, I don't know how many teens that you've worked with, but in my experience working with teens when I was in teaching, it seemed like, especially teen girls, like starting in 7th and 8th grade, there becomes like, and I think it sticks with them through high school, there becomes like this, almost like they like the label to be able to say, I suffer from anxiety, or I got to take my anxiety meds. There's
Right.
something
Yeah.
like, not like Munchausen's, but
No,
there's
but
something.
there is kind of I use the word like a copycat syndrome. That's not a clinical thing, but, and I would say if you look over the last, at least in my career, in the beginning of my career, there was a lot of eating disorders, still very, very serious. And then it went to cutting, and people were into cutting. And everybody was up in arms over somebody cutting, and they were being hospitalized. And really, we know now that cutting isn't really people wanting to take their lives. It's a coping mechanism. And then it kind of waves into bipolar. Everybody and their sister became bipolar. And the number I'm going to say right here is actually an older number. For maybe 10 to 15 years ago, I did a seminar on bipolar, and the bipolar diagnosis at that time had increased 40% in the state of New York. So the question you have to ask yourself, are all of these people suddenly becoming bipolar, or have we expanded our definition of bipolar? And
Right.
I tend to the latter, that, we don't do our due diligence in coming up with these terms. And bipolar in particular has to be something that is not only diagnosed in the here and now, but we need to look back. So it takes a minute. So I can recall a time where I had a person I was working with, and they went to see a prescriber, and in a 45-minute period of time, they were diagnosed bipolar and came back with a cocktail of medications, because bipolar.
This is my biggest fear.
And
that is my biggest fear
with them. Please know, I really felt like they were obviously going through stress and anxiety. It was a very pivotal time, but that was not bipolar. But I see a lot of that kind of stuff.
Yeah, I wanted to say something, and I should have wrote it down. I got to get better at this. That came into my mind when you said how we have these trends.
Yeah.
All right. So we had the eating disorders, and then we had the cutting, and now we're hearing a lot more of bipolar. And is that just, and then you mentioned something about the copycat syndrome, whether that's a technical term or not, but I have noticed rather, I think with social media and the phone, and they all want to talk about it. Now, when I was, I'm going to say in my mid-20s, so I had an eating disorder and I was bulimic. Now we're talking about mid-20s. I wasn't in high school. That was like taboo. Like now I share anything because it is you are who you are. You went through things, or they're your battle scars, and your trophies now, I feel like, make you who you are. Right. But you didn't share that stuff back then. Like that wasn't like, hey, let me talk about this. And now with these girls, like you were saying before, label, and everything has to have a label, and they want to talk about it, and they want to be it. I feel like they want to be it.
Yes.
So I don't know if it's right.
Yeah.
And I don't know if it's just, I'm not sure if when you said too quick to diagnose, or come up with a broader spectrum of terms, or they are too broad. So I don't know if you meant just the professionals, or you meant also the patients, or the people that are seeking help. I feel like they are diagnosing themselves. Like why? Why do we see these trends like this? Why does everybody want to hop on board and nowadays
Yeah,
and
that's a good
be?
question. I would say, I'm sure there's more than one answer here, but I think it's self-concept confusion. You know,
Mm,
and we all grew up in a time where, of course, everybody goes through that, and actually, adolescence is fairly a new common, it's a new term, actually, in the last 100 or so years. But I can't imagine how much more challenging it is with these kids who are trying to figure out who they are with every photo of somebody has been photoshopped.
Mhm.
And
yes.
we had a friend years ago, I forget exactly where he worked, but he said, like, Cindy Crawford is this beautiful model, and her picture was on the cover of some magazine, and they spent 15 hours photoshopping her cover.
My goodness.
So, and that was before, I think, all of this stuff hit. And I thought, well, I never,
Mhm.
my generation, I just bypassed all of that. That was really nothing. But for these young kids today,
Yeah.
you were just talking about that, how people post pictures and they do things to
The
themselves. and-
filters.
yeah.
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 Yeah. I'm guilty of that a little bit. Just a little bit. When you have too many,
Have a good picture, but
these
I guess
lines
it's-
right here.
Yeah. I mean, we've already had the conversation. The three of us have had the conversation about women our age who use filters to put themselves out there to make it look like they don't have a wrinkle or whatever. And
Right.
that's just, who do you think you're kidding? Like,
Right.
seeing you in person, and that is not what you look like. But what I was telling her was, what's more disturbing is girls my daughter's age, 18, 19, 20, who have nothing to hide,
Yes.
are using
Yeah,
filters,
Yeah.
and I don't mean like the filters with the bunny ears. I mean using filters to make their face look as flawless as possible.
Well, that's a
when
lot
they're
of culture pressure.
yeah.
right
And
there.
so that
Mhm.
brings me to, because what I wrote down was, I wonder how much social media and those filters and the way people, the access that we have now to Photoshop ourselves, like the
Mhm.
Cindy Crawford cover, how much of that plays into potentially more girls having anxiety. Because, and I just want to say this before I forget it, because in that documentary, if you haven't seen it, The Social Dilemma, on
Oh,
Netflix,
I didn't.
they were talking about how what we're talking about with the filters and the young girls, and how the desire to try to be as beautiful as you can be and competing against other people. And I post a picture, like her daughter was telling me last time I was here that she has a friend who will post something on Instagram, and if she doesn't have a certain amount of likes within 2 minutes, she deletes it.
Yes.
Because
Oh my gosh.
on The Social
Mhm.
Dilemma, they were talking about, and I'm sure the boys do this too, but they were specifically honing in on the girls, how the girls will post something and they just keep going back and going back and going back and looking to see how many likes do I have. And then that probably feeds into who they think they are, their value as a person,
Yeah.
right? And
Yes.
that comes back into the other point was, oh, well, actually, I wanted to say this. I'm sorry. But in The Social Dilemma, they were saying that girls, like 20 years ago or 15 years ago, the suicide rate of girls was a certain rate, like in high school, but now that rate has like tripled or doubled, but the age is getting less. Like when it used to start at 12 and 13, now we're talking about 9 and 10-year-old girls who are doing
Yeah.
this. And then I think what that ties all into, and you're going to have to ramble on, like you're going to have a lot to say after this, but what I think that all ties into is girls having a real firm sense of self.
Mhm.
Do we give that to them?
Mhm.
I feel like even if we give that to them, though, when they have that phone in their hand 24/7 practically, it doesn't, I don't want to say it doesn't matter the family values, but you're competing with something that you really can't compete with,
Mhm.
so it's a matter of having to take that phone out of their hand, which becomes really difficult. But I'm sorry, I jumped in. So
No, I mean, I'm sure there's plenty of answers here, but we all know our own kids best, and some of our kids may have a propensity for insecurity more than the next kid. So we need to kind of be aware of that again, genetic predisposition. We need to be mindful of our family values, what our expectations are, and solid boundaries and a firm no never hurt anybody. And then
I like that.
the third piece is, if it was my kid and I was concerned about him, I would want a professional who is experienced with working with that age group. Because if you don't have the experience working in that age group, then I think it would be harder to discern and separate out what is normal for this age group and what's, some bells are happening here, and I think we need to be worried. So that would be my recommendation for anybody out there listening. If you're worried about your kid, find a clinician who has experience with that age group, because they are a different sort of breed. And as every decade kind of comes and goes, like I said, different things come to bear. And the other thing that clinician needs to do is, as you get to know each patient or client, let's just say I have two clients that I'm working with, client A and client B. They both report to me their anxiety is at 8 out of 10. All right, that would be typical numbers that they're coming for. But as I get to know client A, their 8's really a 4 in my clinical view. And client B, 8 is like a 9.5. So I'm objective to them, and I just bring in my years of experience from maybe the hundreds of people I've seen. And then I get to know that somebody might be more hyperbolic than the next person. And I can still work with that. I understand what their numbers mean for them, and we can renegotiate that. But we have to ask really good questions to get the answers we need.
Right. I wanted to, and then I'm going to be quiet because I feel bad. I feel like I'm jumping in so quick that Jen doesn't have a chance to even talk. So I just want to get this out, and I'm going to try to be quiet for a little bit. Back to, hold on, I want to shut the door because my husband's blowing his nose.
You just let everybody know what Carl's doing, and we can't even hear it.
So I just had a thought when we were saying, what is this that everybody's jumping on board? Everybody meaning our younger generation, and they are talking about the copycat syndrome, or they're all talking about, I have this or that. I had a thought when you guys were talking that, what if, like, I've told Rebecca to really self-analyze herself. I've always been very open as she was growing up about my feelings or what I was feeling, age appropriate now, in front of her. So what does this generation maybe more apt to understand what's going on with them, or to dig a little bit deeper than maybe we were when we were younger? Does that make sense what I'm saying?
Yeah. I'm not sure how to.
More
answer that.
self-aware?
I think they're more aware of superfluous verbiage,
Mm,
but
right.
the real meaning of that. And that actually brings to mind something I have my clients do regularly, is I have them type in an emotion wheel. You can Google that. There are several different types. And basically what I'm working with clients in a variety of disorders is emotion identification. So just being able to expand what it is you're feeling, and doing that can help discern, are we stressed or are we anxious? And
Oh, wow.
because
Yeah.
what happens is we kitchen sink, we're feeling something, we feel agita, and we just label it for ourselves. And if we dissect it little by little, we go from the macro to the micro, we can see, well, maybe it's not really anxiety. Maybe you're feeling insecure. Maybe
Right.
you're feeling unloved. Maybe you feel distrustful. And so emotion identification would be the first component of that. And being able to recognize that's what I'm feeling. And now I have the language to communicate that.
Right.
We don't teach any of that kind of stuff in school. It's kind of like an EQ kind of thing, if you know the difference between EQ and IQ. Some people just, they have a better sense, but let's face it,
Yes.
most of us didn't have that, and we had to kind of struggle to figure that out.
Oh, gosh, yes.
Can you just tell everybody what EQ is in case people don't know?
Oh, EQ is like emotional intelligence. So it's not necessarily related to IQ, but you can have somebody that's super smart and, can't find their way to the grocery store. They would have a low EQ and a high IQ. So EQ is having people, skills, resilience, street smart, being able to read the room, being able to sense you don't even know somebody, but they seem a little hostile, like kind of. And so actually, I think the whole thing came about was somebody was doing a study and they realized that many people who were CEOs of companies were C students, but they were good with people.
Right.
And so this whole kind of, feeling based psychology came along.
I want to jump in, but I'm gonna stop. I'm gonna force myself to stop and let Jen insert anything right here. But I'm gonna write my thoughts down.
Oh, thanks. I have a couple of questions, but I'll just ask one for now. And if there's time later, I can ask more. Can anxiety and depression change over time?
Can you tell me what you mean by that question?
Can it, say, someone is on medication,
Yeah.
okay? And I know that sometimes over a certain period of time, and I'm kind of curious about this, why doesn't the medication work any longer? And then I guess my second question would be more related to the first. Is there just like a baseline condition, but over time, notwithstanding like super stressors, like can it get better? I guess is my question. Can either anxiety or depression get better?
Yeah.
Over time?
Yeah, I think it all depends on the person. So I would say that there are some people that will go through, anxiety, and maybe that's just about somebody will go through a clinical depression and that's one and done. Statistically, we know if you've gone through a clinical depression, there's a greater likelihood that it'll revisit you down the future. But it gets complicated because we consider anxiety and depression neurobiological twins, meaning they're tapping the same neurotransmitters in the brain. And so what we need to do is ask the right questions to find out if there is a root. Is the root anxiety or is the root depression? Can it be equally both? Yes, it can. But oftentimes, I think one's usually bringing the other along. So since our topic, we started talking about anxiety, I would say that I define anxiety when I'm talking to people as treading water. So if you think about being in a pool, you're constantly in motion. Again, that agita, and that's that constant sense of agita, and it's horrible. And the fatigue that comes with that treading water is the depression that comes as a result of the unmanaged anxiety. So, Jen, to your question, is that it can change in the sense that if it's not too severe, people can learn really good coping techniques, move on, and that's something they went through. Stressors could have exacerbated that. If we're looking at a significant genetic predisposition, then I think it's realistic to say, hey, you have anxieties, I have migraines. So we just got to figure out the best way to negotiate this moving forward. People going on meds, they need to know that it might be the first, the second, or the third medication. So you got to be, I tell people you got to be in the game for at least 6 to 9 months to find the right medication at the right dose. And then once you do, you might be good for 2 or 3 years. And then I've had people who go off and then, they might be fine for whatever. And then they come back because depending on the origin, they're going to have another bout. So would they go back to the same medication once they were off, or would they try something new because you kind of get used to a medication? So people that are having chronic anxiety, depression, or obsessive compulsive disorder will need to change meds as the years go by because you just get, accustomed to them.
All right, so here's a question, because now I'm asking for myself, because I'm not a person who really suffers chronically from anxiety and depression, but life issues the past couple of years have brought up certain things that I've really only felt better since being on antidepressants,
Right.
or an antidepressant.
Right.
And whether that's to treating anxiety or depression, I'm not really sure. But so my question is, when I feel like I've reached a place in my life where the problems that are causing those feelings are no longer problems, do you think my body will have been used to that medication, that when I decide to go off it, my body will react?
I think you'd be the perfect candidate to not need it forever. So, that you're kind of a case in
And
point.
so how do you know when you
so
don't need it?
When you feel that your environmental circumstances have reached a stability, and you feel that you've reached an emotional stability, and you have a sense of security, like any kid, I feel like I can go to that next rung up on the tree.
And you need to like wean?
Yeah. So the slower you wean off and the slower you wean on to any drug, you're going to mitigate side effects. So when people are very nervous about that, then I just go slow as slow can be. So you can, if you're doing Zoloft at 100, then you'd go from 100, you go to 75, you go to 50, you go to 25, and then you'd break 25 in half. And then once you're at the smallest, you go every other day, every third day. I mean, as slow as possible. And, ultimately, if you wind up needing it again, okay. But, when we're looking at situational impetus, if you will, then I think it's very common for people to go on and off.
Okay, that's good to know. I like that.
What else, Jen?
I was going to ask, so, medication obviously is like super helpful for a lot of people. But what if, someone is in therapy and maybe, they're also, taking medicine, but maybe they need more, like you recognize, or, family members, or they recognize themselves that like, this is becoming a little bit more than we can, the person can handle. Like, what would come next?
I'm just wondering if you can reframe the question for me.
Okay. So what I'm thinking is, I know that I've seen some programs out there. So like there's, talk therapy, and then there's what's called the DBT and CBT kind of stuff. Like, can you explain what they're all about? And
yes,
is that a supplement to talk therapy, or is that something you would do instead of talk therapy?
So that's a good question. There are different types of therapy. And when I'm encouraging family and friends to find a therapist, I want them to do their due diligence. I want them to get somebody who's going to do something. So let me just say that if I had to give a percentage, I'm going to say 5 to 10% of the clients that I see out of 100%, we do talk therapy. And essentially talk therapy is humanistic in nature. I'm processing out loud with you. We're just chatting. I'm not in charge. I'm not telling you to do anything. And there are some people that they just need that safe space. And that's all we're doing. I would say 90% of what I do is more in line with the CBT, where we're doing something that there's particular techniques, particular strategies. I always give homework. I'm always having a checklist that I'm going to go through every time that we meet to follow up. Also, it's a gauge for me to see how invested you are. So if you're coming after 6 weeks and you haven't done any of your homework, then it's not right of me to continue a charade. I'm going to say, well, let's go back. You identified these goals. We've been trying to meet them, but you're not really following through. What's like kind of bringing it back to whatever the goals were. So, CBT and more directive types, or rational emotive therapy, these are more directive. I tend to have that kind of personality. And so that's kind of easy. But there are therapists who might only do this kind of processing when really what somebody needs is more of that CBT. DBT is a type of CBT.
So we got to say what those mean, because people won't know.
Cognitive, cerebral thinking.
Cognitive behavioral therapy.
Behavioral therapy. So your cognitions are the thinking that drive the behavior. And so that's what we're focusing on. DBT, dialectical behavioral therapy, is a type of CBT. And, so I think depending on what the issue is, we want to work on very particular strategies. So maybe we need to get your, to do something in particular. That's a behavior. Anything that can be seen or observed by somebody else is a behavior. Maybe it's your thinking that's not quite right. You're always kind of going to the negative. Everybody hates me. Nobody's talking to me. And that could be not it at all. You might be in the room with two shy people, and kind of reinterpreting those types of internal conversations. And or an emotion. Some people are just more emotional, kind of going back to what somebody said originally about hormones. And let me just say this, and then I'll
Yeah.
So particularly if I'm working with women, well, all my clients do a mood tracking number. That's part of their ongoing homework. So mood tracking for anxiety or depression or obsessive compulsive, whatnot. And I do a 0 to 10. So I want to know every day what that number is, and I track that over time. And I do that because I have these numbers and I can see objectively, are we moving? We're not moving at all. Then maybe we add medication. I can see, oh, the numbers are going. Then at the same time, I'll have them track their cycle. We'll put it on the same calendar. If we find that, gosh, the numbers are exploding only once a month, well, then that tells us something different as well. And people who have issues with their mood related to their cycle may not need medication every day of the month. They might not only need it 2 weeks of the month. So doing a lot of tracking, a lot of homework, a lot of follow-up, asking the right questions can kind of help steer that a little bit.
Yeah, well, what you were just saying reminded me of what we were talking about maybe 2 sessions or maybe 3 sessions ago, when we were talking about the effects of the mind chatter. Because we remember we had there's the thinking that leads to a feeling or an emotion that leads to an action, and then repeated actions over time can create an environment. And
Yeah.
so we were talking about, like, what kind of environment are we creating just because of our thoughts? But I wanted to go back to something we were talking about before, when you said something about the emotion wheel, because that's something that my therapist has used with me. And this one hasn't aired yet, so you probably haven't seen it, but we had one of our last the last session on mind chatter, we were talking about sadness, and how for me that wasn't really an emotion that was modeled and expressed in a way really expressed, right? And but anger was.
Well, anger is, yeah, that's why anger is going to be in the center circle of the
Yeah,
emotion.
right.
It's
But
easier. Yeah.
so when you were talking about the emotion wheel and identifying that emotion, and then what the outer rim emotions could be or feelings could be that lead to that emotion, so people can really pinpoint what they're feeling. How parents didn't do that when we were growing up, and I don't think parents do that now. So how do parents raise kids that can really become aware of what they're feeling, real specific, not just anger, not just sadness, but how can we do that?
Yeah, I mean, parents are just trying to do the best they can with what they've been giving, but obviously modeling any kind of behavior is going to be the number one thing. This is a little bit off topic, but I remember my son had a seizure disorder when he was, I forget, 1st or 2nd grade. And the neurologist explained to him exactly what was going on with his brain, and he repeated it. And so when we would meet people and it came up in conversation, we would look at him and he would be able to articulate what it was. So part of what I thought was helpful was the freedom to be able to discuss, which in the era that I grew up, you didn't do that. In fact, nobody even said the word cancer. They used to just say C, so the freedom to be able to say that I have this, that I have that, and that we're just offering an explanation of what it was. It's a matter of fact. I think there's a freedom in that, and that can be modeled in the family. And, I mean, it's hard because parents have so much going on. When you have kids, you're trying to get your profession going. You're trying to have enough money to have a house. You're usually juggling more than one kid. So there's a lot. I would never want any parents to feel, oh, I shoulda. We all shoulda.
Yeah.
But we can model anything that, like you had mentioned, Maureen, about sharing somewhat with your daughter. I think that's great. Let her know at age appropriate different things, because then it's okay. It's not taboo. to feel
know-
this or that.
You know, it's difficult as we're talking about this, and some of my guilty parenting techniques. Well, no, they weren't techniques. They were bad choices. I was thinking about when Becky was saying, how can you help, how can we help our children to express themselves better? And you were saying parents are just doing the best that they can. I'm thinking about when I was going through a divorce, and I keep bringing this up in all our shows, but it just seems so relevant in some of, things that we're talking about. Man, that's really difficult when you're going through a divorce and you're trying to help your child to be stable and understand themselves, and you're not. And I know that you're not supposed to show how torn up you are and break down in front of your kids. But I'm going to tell you, if I had to go back, if I could do it different, I would have, but I don't know if I would have been able to have all my shit together and not be so outward with, I wasn't anger running around the house screaming, but very emotional and a lot of, crying and just, it was a bad time. So, so I guess I'm just relating this when you said, how do we help our kids? But how about a lot of parents going through divorces, or there's just a lot of things that are going on in these days, parents that are working all the time and they just don't have time to spend with their kids because they're coming home late, or they're just in bad situation because the parents grew up really crappy and now they have a crappy home life with their kids. And I don't know.
Yeah.
This is relevant. It just all starts swirling in my head.
Yeah. If they stay in my mind. Oh gosh, it just.
Oh, that's the worst when it floats away like that.
Oh, I was going to say, going back to the modeling, as a parent, it's continual failure. So one thing we can do is we can always circle back and say, hey, I was really upset. I blew it. Would you forgive me? And just,
Yes.
that was one thing that I tried to instill with my kids when they would even fight with each other, to apologize and ask forgiveness. And that close that loop. And even now that all my kids are adults, it does make, because we all, you're close and you snap at each other and this and that, and then we come back and say, I'm sorry, I was being grouchy, or I'm smart. And so that's one thing. But the second part of your question would be self-care, not self-care in a selfish way, but self-care in an appropriate way, meaning you can't water your kids if the well is dry.
Right.
So you have to be able to find ways to water oneself, whatever that looks like. And so that's where sometimes having a brainstorm session with a friend or a therapist can help remind you. A lot of people say, I don't have time for this. Well, you have time. We're going to work to schedule that out. And
right.
we'll find, even if it's 10 minutes in the morning and 10 minutes at night, we can get you at least 20 minutes for you to get a little water back into your soul, that kind of thing. So, yeah.
So sticking with the divorce theme, and what I was picking up from what you were saying, Maureen, is it was making me have questions in my mind of what is the appropriate amount of what you're going through and what you're feeling in those situations, like a divorce, to not share, but to let your kids see. Because are we messing them up by pretending we're all fine?
Right.
Or is it honest and authentic to share a certain portion of it? What do you do there?
Yeah, that's a tough question. And I certainly am not a specialist on divorce, but I would say keeping in that primary emotion wheel, mommy's feeling sad.
Yeah.
Mommy's feeling angry. But I think to go beyond that with our kids burdens our kids.
Yeah. I'm going to agree with you. I'm just going to say this real quick because I cried a lot like bawled. Now I bawled, I think I shared this before, in the shower. So it was like, but she knew, but she heard it, she knew it. I had a tiny little house. So I didn't openly just bawl, in front of her, but there was a lot of crying and she was scared. Like we talked about it afterwards and I did apologize and we have had these conversations, but the damage is done. But we're very open about it. But yes, I want to, from my experience, confirm what you're saying is true. She was scared because too much anger, too much sadness outwardly is scary for them. They don't know how to process that.
Mhm.
And they're a stronghold.
Yeah,
You
you don't
know?
become the parentified child where they feel like they have to parent you and they've got to protect
Right.
you and then we've robbed them of their youth.
That's
Yes.
a big thing for me is I don't want my kids to see too much because I don't want them to feel responsible to make me feel better.
Right.
Mhm.
Because it's not on them
And
to make
nobody
me
is
feel better.
responsible but you.
Right.
Yeah.
Right.
Yeah. But not everybody is that way.
Yeah.
Some people are purposely manipulative to show their emotions to get other people to try to make them feel better.
Yes. We could do a whole show on that.
Oh, yeah. I'm thinking we have about 6 or 7 minutes left. I want to make sure Jen has any questions. And then I do have one final question that I think will be a good ending question.
Thanks. Real quick, I was just wondering, what kind of therapy is used generally to treat OCD?
Cognitive behavioral therapy.
Okay.
Yeah, very, very particular type of therapy. And just as a side note, depending if somebody's OCD, moderate to severe, they're probably going to need medication, not forever, but to quiet the brain so it can be a place where it can implement the strategies, because it's, I guess, mind chatter, clutter, whatever you guys talked about. It's incessant. And what most people don't know about OCD, if people aren't asking the right questions, the diagnosis can be delayed between 15 to 17 years.
Oh my gosh.
Misappropriated into the anxiety. And the reason that that matters is even though you're going to still use CBT in both of those categories, OCD is a very specific neurobiological brain disorder. And when you're using medication, it is not uncommon that you would need twice the amount of medication for OCD than you would for somebody with an anxiety or depressive disorder. That, obviously it's all different, but generally that's why it's so important that people are asking the right questions.
Is OCD a form of anxiety, and what causes OCD?
Okay, that's a great question. So in the psychological world, psychology is considered a science, but it's a soft science, so it's constantly changing. And so with the advent of the last Diagnostic and Statistical Manual of Mental Disorders, think of an umbrella, if you can imagine an umbrella here. It used to be anxiety was the umbrella, and then you would have OCD underneath. You'd have generalized anxiety, you would have panic disorder, you'd have social anxiety, you'd have phobias. But they have now made the own umbrella of OCD spectrum disorders. So if you think about the obsessiveness or what Dr. Jeffrey Schwartz, who's a premier OCD doctor, calls it a brain hiccup, or think about the records when they used to skip. So similar disorders would be something like trichotillomania, where you're pulling out the hairs, or you're picking your skin, or you're burning yourself. These kind of impulse control issues. Somebody who's eating things inappropriately. So something is misfiring in the brain, and so now we have this whole section of OCD spectrum. So what we know about OCD is that there is a genetic, predisposition. And in some cases, rare, but if as a child, your child all of a sudden is instantly kind of manifesting an obsessive compulsive type of behavior, one thing that they'd want to look at is something called PANDAS, capital PANDAS. And that's with some kind of infection has occurred in the body, and as a result, it's kind of blown up this obsessive compulsive thing. So that's kind of a different category. But typically, again, most of these diagnoses are going to come later, but it's not uncommon. I mean, it's not as common to see it in childhood. And yeah, but again, you'd want to have a therapist that is asking the right questions, because if that gets missed, then they're not getting the help that they need.
Okay.
So
Becky, I just wanted to ask a quick question before you wrap us up. Jen, were you done? Because I don't want to interrupt you.
Yeah, thanks.
Okay. So what do you do if you're looking for a therapist for, I know this sounds crazy, years on and off,
Mhm.
and every time you look for one, you're hitting a brick wall
Yeah.
because, well, maybe your insurance doesn't cover it, but they're all saturated. They're not taking new clients.
Mhm.
So this has been an issue for me over the past, I'll say at least 3 years.
Yeah.
And and then you end up in a facility or agency that they're not asking the questions, and they're like you're talking about. I don't know how you're going to answer this, but
You are not alone, because this is an ongoing problem for so many people. So I would probably, the number one important criteria for successful client therapist is the connection.
Mhm.
More than what their degrees are, the experience, anything like that. You have to, you've got to be simpatico or nothing's going to happen.
Right.
But outside of that, it would be better for you to pay out of pocket
Yeah.
to somebody that you feel connected to and do therapy twice a month
Right.
than it would be to go every week for somebody that's
Right.
And what I would say to you is, like, for anybody's listening to this, if you can, for the first couple of weeks, just do a couple of weeks in a row so the therapist can get to know you. It does take a minute to get an assessment, figure it out, find the diagnosis, come up with the goals that we're going to, work on, and then kind of
Right.
go to every second. I let my clients really, if they want to come every 2 weeks, if they want to come every 3 weeks, I'll certainly give my recommendation, but I want them to have that freedom, because it is a lot of money and a lot of people
Mhm.
are paying out of pocket. But ultimately, I think that's the sacrifice that could be made. And that would be, more profitable for clients kind of searching. Get recommendations, ask people who they've gone to. But in
Yeah.
the end, you have to feel that connection in your gut. You usually know, if it's not after the first, you would know after the second if it's going to work for you. Don't stay,
Right.
don't linger, don't think I'm going to make it work. Find somebody else.
Right. Right. Thank you.
Yeah.
So I have one question before I ask the final question. I just want to go back to the OCD for a second, and OCD in childhood. Are there common symptoms or signs that you can see in younger kids, maybe like 10, 11, 12, or even middle school age? Like, are there common things that pop up with kids who really end up having OCD?
Well, you'd have to think about the definition of an obsessive thought as an unwanted, intrusive thought or idea that pops into your mind, is completely unrelated to something. It can happen when you're sleeping. It can happen and it's irrelevant. So, and there are different types of those obsessive thoughts. There can be aggressive, sexual, religious, you know, thinking about numbers, whatever. And then the compulsion is the act or the behavior of doing something that alleviates momentarily the obsessive thought. So probably the most particular one, although this isn't true of everybody, would be fear of contamination, germ, that kind of thing. So, if somebody's constantly washing their hands, what's happening before you're seeing the washing of the hands is the interrupted thoughts of, my hands are dirty, and now I can't think in school. My hands are dirty. I don't know what the math teacher said, because the desk is sticky and I can't really focus until I wash my hands. So again, it's asking the right questions and seeing it. The parents can see the internal drama that goes on, particularly I think with OCD kids. Interesting enough, many people with OCD tend to be very bright. So they're going to they're still going to do well in school, but by the time they get home, they have spent every resource of keeping it together, and they come home and they vomit on you. You know,
Wow.
maybe the caregiver.
So
Not
intrusive thoughts is a form of OCD?
well. That's the definition of the obsession. The O is
Oh, I didn't know that.
intrusive, unwanted thought or idea, and it could be
Right.
a myriad of things. And then the other thing with OCD is you could be dealing with somebody who has all these symptoms, but if I meet them again 10 months from now, their symptoms may have all changed, but we're still dealing. It's like that whack-a-mole game, you know, you have the big hammer
Right.
and you're hitting. So that's why your therapy is at the root, trying to figure out the brain and form new neural pathways and recognizing, now that's an OCD thought. That's OCD, that's not me. That I'm not OCD, but OCD is something I have.
Right.
It's going to manifest in these symptoms that are going to come and go, wax and wane, you know, for
Yeah.
the rest of your life.
So you just said something else. I'm sorry, Becky and Jen. I feel like I'm like
We're good.
like going at it. You just said something else too that resonated with me, where you said you have a thought. Now, not an intrusive thought, like say, oh, the coffee table's dusty. And this happens to me all day long, constantly, to the point where I feel like, and I'm not sure what ADD and ADHD are because I haven't looked that up, but I feel like I can't concentrate. So I can't go on and finish what I'm doing until I go clean the coffee table. So this is something that happens to me all day long, not just with the coffee table, with every thought, like, oh, I have to clean this in the house. I have to clean that in the house. Oh, I have to go do that. I have to,
Right.
and so I can't pay attention to focus on what I'm doing until I finally get myself in a zone,
Right.
or I've completed all the things that have distracted me.
So it could be just that's a quirk of yours.
Mhm.
It could be, but we don't know until the right questions are asked.
Right,
If you're
right,
doing an
okay.
assessment, you know, there, you have to, especially for OCD, we're gonna ask a lot of questions. We're gonna see how many check marks you have. Then we're gonna try to quantify the anxiety or the stress or the discomfort that feels for you.
Oh,
And
okay,
then we're gonna translate that in how many hours per day have you lost to
right,
thoughts and external compulsions. So that's fairly methodical. But to your point, manifestations of attention deficit hyperactivity disorder, ADHD,
hmm
they can kind of look like it's a separate disorder. Like underneath another OCD umbrella, there can be attributes of ADHD.
mm,
So I, as a clinician, wouldn't be quick to say, oh, you have both. I'm going to say, well, we have OCD. Let's wait before we diagnose ADHD, because it could be that those are just superfluous manifestations of the OCD that will remedy it as we deal with the main diagnosis. But you
Right.
could have two separate disorders also. So it really depends, again, on
Sure.
getting that thorough assessment in the beginning.
Right. Thank you. I'm going to be quiet now.
Okay, and I think that leads to, I think, probably what is maybe the most important question for people who are maybe looking to find a good therapist is, what should we be looking for in a good therapist? I mean, you already talked about you need to have that compatibility.
Mhm.
You need to feel like a connection, but what else should you be looking? Because like, my therapist never really did like an intake with me, you know, like there was no like family of origin questions. I mean, they've come out over time. But I like some of the things you talked about in my mind, I'm thinking she doesn't really do that. So what makes a good therapist? What should people be looking for?
Well, I mean, you can do a lot of shopping online. I would look at what their credentials are, where they went to school, just how can I, you know, what are they determining that their specialty is? And if you find somebody that on paper looks like that matches you, think of it as a job interview. They're interviewing you and you're interviewing them. Like, do you want the job? Do you, you know, are they going to give you what you need? I would encourage you to be assertive as much as you can. Although many people don't know that somebody should be doing an assessment.
Because
So
I
making
wouldn't have thought about that really.
And you know, when somebody's coming for stress as a result of a circumstance, you still want to do it to make sure you haven't
You're not
missed
missing
anything.
something,
Yeah. So I would look at the experience. I would ask them, what do their typical sessions look like? Do you help articulate goals? Do you check it? You know, yeah, I think, to maybe just some basic questions like that. But ultimately, you've got to feel that you're getting what it is you're looking for. So part of it is, what are you looking for? What is it that you need? Give that some kind of thinking through for everyone's self. Everybody needs something a little different,
Yeah. You want to be my therapist?
I can't be your therapist.
She's still my therapist. She's my go-to. All right. Well, this was good. We're still under an hour, so that's good. But I think this was a good conversation and hopefully beneficial for whoever is listening. You three people out there. Yeah. So thank you for joining us a little bit.
Thank you so much.
Yeah, my
Thanks,
pleasure.
Karen.
All right. And we'll see you guys next time.
Okay.
On the Messy
Bye.
Truth.
Bye.